Hello, I'm Dr. Kaiser Munir. I'm a GP with an interest in sports and exercise medicine. Today I'll be examining the knee joint. Thank you to my volunteer. In general, when you examine the knee, the main focus is on the knee, but the idea is to generally assess initially for stability and other joints, the joint above and the joint below. Initially what we do is do a general inspection, and if you could put your feet together please, we make sure to check for any valgus or varus deformities, which there are none here. We check the general femoral alignment and the alignment of the knees, and whether there's any inward pointing. We can also check for tibial position. If you could, I could get you to spread your feet just shoulder width apart there. We can also laterally check for any pes planus or pes cavus there. That's fine if you put your feet together now. We also will generally check for stability. So if I could please ask you to go on one foot and squat down. Thank you. And if you could do the same on the other foot. Thank you. And we're just checking there for core stability and general balance as well. We can make that more difficult if we use a pillow, for example. I can get you to stand on there, please. And again on one foot, squat down. Thank you. And if you do it on the other side. Thank you. Again, there's reasonable stability there, and the purpose of that is to check if there's any ligament laxity which might make the patient subject more susceptible to ligament injury in competition. We also then move on to examine the knee more generally. If I could have you lying down on the couch, please. Thank you very much. And for the purposes of this examination, we're going to focus on the right knee. We start by checking initially for general neurology. So if I could just ask you to say yes if you close your eyes, please, and if you feel me touching your toes.
Yes.
Thank you.
Yeah.
We then can check for power as well. If I get you to push your toes up towards you, thank you, and push down, thank you. And again, we can check for to see if there's any radicular symptoms in the back. If I get you to lift this leg up as far as you can, straight, thank you. Is that causing any back pain?
No.
Okay, and so checking there for no neurological problem. We can also then go on to assess the hip and can check for internal and external rotation, just to exclude any hip pathology, and then we go in a more focused way to the knee, and there's no obvious loss of muscle bulk here, no scarring, bruising or deformity that's apparent. What we then do is focusing on the knee in particular to check for any obvious effusion, and in doing that we can do a patellar tap test to assess for fluid, and slightly more specifically we can do a patellar bulge as well to see if there's any fluid there in the knee. We can then go on to focus on movements at the knee. It's important to check for movements. Could you bend the knee back as far as you can? Thank you. Just push a bit further, thanks. And if you just straighten out please. And if you could just push down on my hand. We've got a degree of flexion there, and on the other side. And we could, if we wanted to assess further, turn the patient onto their front to check if there was any misalignment there of the legs. Could I also get you to just bend the knee there and straighten out the foot? That's fine. So we're checking for the power of quadriceps there, and bend back for me. Thank you. So we're checking for the hamstring power there. And if I could get you to point the toes up, we've done that already, but that's checking the anterior compartment, and push down. So checking for gastrocnemius as well. In palpation, we can then look at the structures in more detail. So look at the superior aspect of the patella, palpate the patella and the infrapatellar notch. Also, if there was arthritis, we could palpate and see if there was any arthritis just lateral or medial to the patella. And then feeling structures in more detail in the knee joint, particularly the joint margin where there may be tenderness in the event of arthritis or meniscal or ligament problems. We can then go on and do more specific tests looking at other structures in the knee that may be affected by injury. And one test we can do, I'm just going to perch on the edge of the couch here, is to check for the collateral ligaments. To bend the knee slightly, so it's important to have the knee slightly flexed, because otherwise when the knee is fully extended the joint is locked. Checking therefore the medial collateral and the lateral collaterals, and the knee is nice and stable there. With the patient also in this position, we can do a Lachman's test to check the anterior cruciate ligament, and with the knee slightly further. I'm just going to sit on the edge of your foot now. We can also push and check for posterior cruciate, and they're stable here. What we can also then do is assess the menisci, and the way we do this is a McMurray's test. With the knee virtually fully flexed, we can initially apply a varus strain and extend the knee with our hand over it, assessing for a clunk or click. And we can then do the same with a valgus strain and assess for any clunking or clicking. And there is none here. If I could just have you standing up, we can then, using the body weight of the subject, just stand here, thank you, we can then do a standing McMurray's test. If I have you please put your feet in that position and squat down, we can then, that's fine, if you stand up, that would, okay, if you do that again please. Okay, it's not causing any pain, that's fine. Is there any tenderness on that?
No.
And if you point your feet inwards please, thank you, with your toes together, and again squat down, again checking there for the medial menisci. You could lie down on the couch again. That then concludes our knee examination. To be thorough, one would like to do a full neurological examination of the legs to ensure there was no missed neurological problem. And one would also examine the other side.